All right, I think now's a good time to get going. Welcome, everybody. Thank you so much for joining us for our webinar today. We're so excited to have you. Today's event is titled Bridges to Better Care. We're looking forward to having a really rich conversation around integrating data systems to streamline care coordination. We have a couple of wonderful guest speakers with us today from Contra Costa County, California, and so we're really looking forward to our conversation today. Today is Wednesday, June 8th. We're getting started right at about 1 p.m. Central Time. A quick disclaimer before we get started. This project is supported through the Council's cooperative agreement with the Health Resources and Services Administration. So the contents of the webinar are those of the Council and aren't necessarily endorsed by HRSA. Also, please note that this webinar is being recorded and will be published on the Council's website, among other outlets that help to promote our training and technical assistance activities online. For those of you on the call today that aren't familiar with the National Healthcare for the Homeless Council, we are a national membership organization that provides training and technical assistance to those that are providing or overseeing services at the intersection of health and homelessness. This is reflected in our mission, which is on the screen now. Grounded in human rights and social justice, the National Healthcare for the Homeless Council's mission is to build an equitable, high-quality healthcare system through training, research, and advocacy in the movement to end homelessness. So we encourage any of you that are looking to learn more or access other types of training activities to visit us at nhchc.org. A couple of housekeeping items before we get going. Today's event is a webinar style Zoom event. So as opposed to a Zoom meeting, everybody on the call is currently muted, but you all will have an opportunity to unmute later on in our Q&A period. But we do encourage you all to maintain engagement, to really type questions or thoughts in the chat feature at the bottom right hand of your screen, which I see a lot of introductions already happening. So great to have you all. But feel free to utilize that feature for any questions that you have, and we'll address them. As I mentioned, we will have a Q&A period for the last bit of our time together today, where you'll be encouraged to raise your hand and come off mute if you feel comfortable and hope to do so. And finally, we will also have an evaluation poll at the very end. We really would love to hear your feedback on today's event to help us understand what we did well, what we can do better next time. So information about the hosts and presenters on today. My name is Joey Kinkle. I'm a research associate with the National Healthcare for the Homeless Council. I'm here with my colleague, Lauren Berner, today, who is the research manager at the National Healthcare for the Homeless Council. And we are here for any questions that you have about the event. We're also really excited to preside over the conversation today by helping along the Q&A. So please do let us know if you have any questions. But we're joined by our wonderful presenters from Contra Costa County, California, Lene Altman and Allison Stribling. We will in just a moment hand the mic over to them, but we wanted to take an opportunity before to do a little bit of level setting. We know from the Council's perspective, we've done a lot of work and had conversations around data, so we know that every community is really different in their journey with data, in using their data, in establishing data partnerships. So we'd love to learn more about who we have on the call today, your familiarity, and what's really going on in your communities. So I've got a couple of poll questions that I'm going to pull up here. And so you should be seeing them launch now. The first question being, how are you familiar with the concepts of data integration and data sharing across sectors? 1 being, I'm not at all familiar. 4 being, I'm an expert. We figure that this presentation today will be really helpful to folks at all stages of their understanding. And then the second one is, where is your community in doing data integration work? Some of you might not be doing this work at all. Some of you might be doing this work but looking to grow. But again, we hope that this presentation will be helpful to folks at all different familiarity and stages. So thank you all. We're seeing a lot of great Answers coming in. Somewhat familiar seems to be the highest choice for question number 1. And great for the second question. It looks like folks are doing this work in data integration, but are really looking to grow. So we really appreciate you participating in this poll. So I'm going to end out the poll here. And as we transition to our speakers today, we'd also love to hear from you in the chat. I'm going to type in our final question for level setting, which is, what do you hope to get out of today's conversation about data sharing? We really want to make sure that this is a useful time for you all, so please consider sharing your thoughts in the chat as we hand it over to our speakers. So Lene, I'm going to stop sharing my screen and allow you all to share yours.
Great, thank you. I'll get our slides up.
Okay, thanks, Allison.
Welcome, everyone. We're excited to be here today and excited to talk through and answer any questions, but also hear from you all about what you're doing. It sounds like a lot of people are really moving forward with this integration of data systems, and I'm curious to see, some people may be ahead of us, some people may be behind us, some people may be in the same place. So I think this will be a wonderful conversation. I do want to just mention that our colleague Michael Fisher, who is from our Health, Housing, and Homeless Division, unfortunately he is out sick today, so he will not be joining us. It's very sad to miss it, but Allison and myself will be here. So just a quick introduction. My name's Lene Altman, and I work with our Healthcare for the Homeless program here in our Public Health Department, and I also work very closely with our Health, Housing, and Homeless Division, as well as with our new CalAIM state initiative that is coming out. And then Allison, I'll let her introduce herself and then we'll walk through.
Good. Hi, everyone. Allison Stribling. I also sit in the Public Health Department with Lene on the Quality Improvement team and work very closely with Healthcare for the Homeless and some of our other programs within public health that serve our homeless population. I also act as kind of a liaison with our business intelligence or informatics team, which supports us with a lot of these data sharing efforts. So we're excited to be here and talk through some of our recent work in this field.
Thank you, Allison. Okay, so just a quick little agenda. We'll go through Contrast Health Services, just an overview here within the Bay Area, our project background, data infrastructure and builds, some of those relationships and collaborations, and then the benefits and lessons learned, and then we'll open it up for discussion. So Contra Costa Health Services is within San Francisco Bay Area. We are one of the 6 Bay Area counties here in San Francisco Bay Area. We are a county-run system, an integrated safety net system, and we coverage and care for over 200,000 people. So our Healthcare for the Homeless program sits within our Public Health Division, and then our Homeless Services sits within our Health, Housing, and Homeless Division. We also work very closely with our Behavioral Health Division, our health plan, emergency services, our regional medical centers and health centers and detention, and then obviously our hazardous material and environmental health. Okay. So as I said, Healthcare for the Homeless sits within our Public Health Department. We are a healthcare delivery provider for patients experiencing homelessness here in Contra Costa County, and we operate both medical, dental, and behavioral health services in traditional clinics, as well as non-traditional settings, such as mobile clinics, outreach teams throughout the county. And then we do document within our EHR, which we use Epic here in Contra Costa County. And we also have the luxury of a lot of our network providers, as well as outside external network providers and private insurers are also within our data sharing agreements within our EHR, so that we do share information across systems in that way as well. Our Health, Housing, and Homeless Division, of which we call H3 here in Contra Costa County, is also a dedicated division within Contra Costa Health Services. It's an administrative entity for the homeless continuum of care here in Contra Costa, and it operates our street outreach teams, emergency shelters, and a lot of our permanent supportive housing. And they are also documenting within HMIS. Bitfocus is the system clarity that they use.
Great,
I'll-
thanks. Yeah, thanks, Lene. So I'm going to kind of take over from a little bit about the divisions to a little bit about Contra Costa's data infrastructure. As Lene mentioned, we're a very large integrated county health system, and we're blessed to have a very robust IT department internally housed within CCHS. About 10 years ago, our IT team led an effort to transition most of our county systems to a shared EHR, which Lene mentioned is an Epic platform. And they also developed an internally managed data warehouse that is able to take information from the EHR and then some of these other key systems listed on the slide and centralize it in one place, which is the goals was really to facilitate data sharing between all of these systems and the Epic EHR, as the EHR is the point of care for the majority of our service providers. Allows us to aggregate data from these systems for reporting and strategic planning purposes, and also for some risk stratification, overall population health management, and identifying gaps in care. So some other systems in addition to Epic, we have our mental health billing system, EMS systems, our jail management system that Detention Health utilizes, and then now, thanks to the work done in this project, our HMIS system, but previously HMIS was segmented from this data warehouse setup. As Lene mentioned, we're also able to receive some external data through Epic's built-in health information exchange, which is Care Everywhere. In the Bay Area, we're lucky that all of our main hospital systems in the county and surrounding areas also use Epic EHRs. We have pretty robust data sharing agreements with our social service department, which allows us to bring some benefits information into the EHR and into the data warehouse. And then on a smaller scale, some community-based organization data through provider portals. Great. Okay. So as I mentioned, we're very blessed with this robust centralized data warehouse, but prior to this project, there was a very clear gap in the data sharing between our EHR and our HMIS system, which stores the vast majority of our homeless documentation. So in Contra Costa, we have over 250 programs that enter their program service information into HMIS, serving over 9,000 unique clients per year. And prior to this project effort, there was no way to share that information with our providers in the EHR to collaborate on these shared clients. So in 2016, Contra Costa began a pilot project called Whole Person Care, which was a 5-year Medicaid waiver pilot program. It was extended for a 6th year due to the COVID-19 pandemic, but it was authorized by Centers for Medicare and Medicaid and administered by the California Department of Healthcare Services. Contra Costa, as a pilot participating county, was awarded $200 million for service delivery and technology projects. And Contra Costa really took this as an opportunity to make better use of our data and expanding the scope of data sharing and closing gaps that we saw in our current systems. And so for our homeless program specifically, we were able to leverage whole person care funds to implement a new HMIS system, BitFocus, like Lene mentioned, in 2017. And BitFocus was better able to be integrated into our data warehouse, which is why we made that switch, specifically selected that because we were able to bring it into the data warehouse and develop a bidirectional data exchange once that data is stored in the warehouse. So that we can better share information, apologies, typo on the slide, between HMIS and the EHR. And then the last bullet there, even though not directly related to HMIS, I did want to mention that another large-scale technology project from Whole Person Care was bringing our mental health clinics, which were part of our behavioral health division, into the shared EHR. Previously, they were on paper charts prior to 2016. So this was another very large technology effort funded by Whole Person Care and allows our mental health clinicians and care providers to also benefit from the homeless information that's now available in the EHR. Okay, so a little bit more about the actual data infrastructure and builds. So what we did is working with the HMIS vendor BitFocus and our informatics team or our IT teams, we developed a nightly file exchange process, which brings our data from HMIS into the centralized CCHS data warehouse. Our informatics team also developed a patient matching algorithm that's applied so that we can match the client information in HMIS with the patient information in the EHR and try to create a match. Once that information is in the central repository and matched, we then bring over case manager name, title, and contact information from the EHR care team to HMIS so that it's visible to homeless service providers who are working with those patients. And then on the other end, from HMIS to EHR, we bring in any housing programs that the client is actively enrolled with, as well as the contact information for that housing program so that care coordination can occur. And then just a quick view of what this kind of looks like in both systems. So on the left hand, we have the a care team snapshot. So this is the location that our EHR informatics team has really said this is where our system will view and interact with care team information. So it was important to select the care team as the receiving area for the HMIS data. And you can see at the bottom, that last little line there, we have one of our shelter sites listed. And then although blurred out, the phone number for that site. And they're all tagged with this relationship of housing program so that other care team members know where the client is currently staying and how to contact that location, and that if they weren't familiar with the particular name of the program, that is a housing program. And then on the right-hand side is our HMIS client profile, and down at the bottom, identified 3 major case management programs that CCHS provides internally within our health system. And we bring in the case manager name, which program they're affiliated with, and contact information, again, blurred out, but so that that information is available to homeless service providers to reach out and begin that care coordination. I'll turn it back to Lene for this relationships and collaborations.
Thank you, Allison. So I know there's a lot of questions around HMIS, and I already see a lot of information about our bilateral communication. And so we can definitely answer specific questions because I think that will be more helpful at the end. But I do just want to touch on really one thing that was one of the most important outside of our data warehouse, but is really having leadership vision and buy-in for this process. So this was something that we were really striving for, knowing to coordinate systems. We also really needed a dedicated program manager to kind of coordinate this across programs. That was my role, was to really kind of be the champion for this project and really continue to push it forward. In our large system of care that we have in large county system, there's a lot of different projects going on at all times. So we really need, one of the recommendations we have is really having a dedicated person that's going to keep pushing this process and continue to coordinate with both systems as well as divisions and leadership in each division to kind of keep moving this forward. I had a really good relationship with the Health, Housing, and Homeless Division, who also had people within our business intelligence unit, which is like our IT department, working closely with them as well and developing really close relationships with them. And then the knowledge and understanding of both systems. So I had to really make myself familiar with both our homeless management information system, as well as using my knowledge from our electronic health record through collaborations, using the system. So getting access to the system so that I could be educated on the system and really see and shadow kind of where our case managers, where our CBOs using HMIS, how are they using HMIS? And that's kind of where we landed on that client profile page, really making sure our information is listed on that first page. One of the things we've learned from a lot of CBOs that utilize HMIS were that they use a lot of different fields within HMIS. Many of you may know or may not know, but there's a lot of different capabilities within our HMIS system that focus specifically, which is awesome, but it can also allow a lot of people to document in different ways. One area that they are consistently using across CBOs as well as within our divisions is that client profile page. So that was something that we knew moving forward right away, like that's where we need to include that information. And then direct involvement in services rendered to assess kind of the benefits and the challenges. So we did move this forward with one case management program, for example, and recognize that there are many other, at least 2 other main case management programs that were really holding patients for years, if not longer. So really making sure that we're involving all of those case management services and not just some of them. We also consistently will see kind of breaks in systems as we update things in our EHR, or we update things in HMIS, or there's new programs added to HMIS. So the COVID pandemic was a perfect example. Here in California, we had the opportunity to get Project Room Key funding, which allowed us to open some hotel sites and decompress our congregate style shelters, which then created new housing programs and new shelter programs. So really making sure, like my role in that was really making sure those were now updated in this data sharing agreement, which it can be challenging if this person doesn't exist because there's so many moving pieces, especially with the pandemic, to kind of forget that piece is so important. We also use this piece, which Allison will speak to a little bit in the next slides. We really use this bilateral communication in a lot of our reporting for our COVID pandemic. And it was really beneficial to kind of see how we move those people from the streets into our shelters, into our hotels, and how they move throughout our system of care and then ultimately housed, which is wonderful. And then the other thing I would say is workflow development and implementation, really based on that data sharing. So there really needs to be buy-in from those leadership teams at the service level as well, so that the systems are using this. They are assigning themselves as case managers so that it's shared on both ends. If phone numbers are updated, we're really making sure that they're updated in both systems of care, and then making sure that the implementation is actually working. So are the case manager information coming over? Is it not coming over? As I stated before, we have seen some breaks within the system that we've had to fix, but we only know that because we're directly involved in those services rendered and part of that implementation process. And so I do think there's a lot of different levels of involvement, and I have definitely seen that a dedicated person, both from the EHR side as well as from the HMIS side, is really, really important in this implementation.
Great. Thanks, Lene. Lene hit on a lot of them, but we wanted to quickly kind of run through some of the tangible benefits we've seen from this project. I think Lene spoke to really the most important one, which is allowing us to better serve our shared patients. So this visibility of who's working with the client and where they are within our homeless continuum of care allows those direct service teams to collaborate, reaching out to each other, and breaking down silos, reducing duplication, really putting the patient at the center of this collaborative care team process. From a systems perspective, our data warehouse now includes data on whether someone has access to homeless program in the last 15 years. And then we included HMIS indicators in this internally developed kind of definition if someone is currently homeless. So aggregating indicators that are used in the EHR as well as HMIS to say, we think this person is currently experiencing homelessness. These inputs are used for predictive analytics and our risk modeling so that we can identify some of our highest risk patients and then proactively enroll them into services. So we know they're eligible, the service it has a enrollment criteria of homelessness. We know who that population is. And what this allows us to do is really take a proactive approach so that the responsibility isn't on the patient or even other care team members to request services. Rather, we know they're eligible. Let's just start the outreach process and offer the service to them. And then lastly, as Lene mentioned, our coordinated COVID-19 response. So because we had this patient data available, able to more effectively coordinate with our partners at Health, Housing, and Homeless Division, really well positioned to quickly identify kind of our most vulnerable our homeless populations, knowing who was eligible for placement into our Project Room Key hotel sites as the vaccine was rolling out, kind of which populations were eligible and able to offer them testing and vaccine throughout the pandemic. All those benefits didn't come without challenges and lessons learned, which are kind of coupling together. The first one that comes to mind is the importance of validation. This is a pretty extensive validation effort is needed and is an ongoing need to ensure that the information that's being displayed is accurate. It's not outdated. It's displaying as expected. And we know that because we're directly involved with the care teams, if it is inaccurate or outdated, you're quickly going to confuse the care team members and ultimately the patient and not have a good level of care. So taking the time, it's definitely cumbersome. Usually identify some data cleaning that's needed as part of that process, but it's crucial to ensure that it's working as appropriate. Even with all of that data matching or data cleaning, we have an imperfect data matching. So this can be frustrating. It's definitely an ongoing barrier, but it's the reality. The patient demographics in the EHR aren't always going to match even close enough to be identified in our matching algorithm with what's in HMIS. And this is just part of having separate intake processes. So it happens, continuing trying to refine and clean up data so that we can improve the matching and improve the sharing. And then the last two are really related to stressing that this isn't a one-time project, but an ongoing process. So as Lenny spoke to during the COVID-19 pandemic, we needed new resources to expand the data sharing to include our hotel programs, to kind of get everyone moved over from their congregate shelter housing status in HMIS to the new programs that are being built out in HMIS, then get that information into the EHR. Recently, our case management programs switched to a new module within Epic, which slightly changed how the care team information was displayed and totally broke the exchange. So the little nuances and little changes require the ongoing resources to just identify, oh, a change occurred. We need to make a tweak and then revalidate and restart the sharing. But to support that, lessons learned, we are very blessed with whole person care funding to make a lot of these really large IT projects possible, but continuing to leverage available funding streams to support those ongoing resources as these nuances come up that we need to address. In terms of next steps, so California Department of Healthcare Services is in the process of implementing pretty robust Medicaid reform known as CalAIM locally here in California. And part of the initiative will establish new housing services as benefits for homeless patients enrolled in Medicaid managed care programs. And so we will be responding to those by increasing the visibility of who's eligible for those benefits, as well as who's actively enrolled in the services, whether those services are offered by care teams at CCHS who document in the EHR or teams who document in HMIS, and making sure that data is part of the exchange. Also looking at how to explore, how to use health information in the EHR to kind of expedite shelter intake processes. So if we know someone's had recent TB testing, that information lives in the EHR. How can we share that with our shelter partners, as well as health history data to populate housing priority placement tools like the VI SPDAT, rather than relying on the patient kind of disclosing their health needs. We know their health needs from the shared information in the EHR, and do we have the opportunity to use that to support these tools and completion? Okay, so we wanted to leave plenty of time for questions and discussion. So looking forward to the discussion section. Thanks, I see Lauren popped off, so maybe I'll turn it back over to help facilitate that.
Great, thank you so much. Let me allow people to see my face so I'm not just a talking head. But first of all, thank you so much for sharing the work that you're doing. Really appreciate you taking the time. I know that there have been a lot of questions in the chat, as well as a lot of folks expressing some jealousy or hopes for consultation and consulting, because you've done some really excellent work in your community. And I know that this is something that a lot of communities are hoping to be able to do as well. I have been copying questions over. Please feel free to keep putting questions in the chat, and we're just going to get through as many of these as we can. And we'll, I know that there was a question in the chat about being able to access the chat or an FAQ later. Joey and I will figure out a way to make sure that this information gets out. We will be sharing the recording. So very interested in doing more of this work with all of you in the future too. The first question that I have here is someone would like to know and get consensus on what is the TMI, too much information threshold when deciding who qualifies to enter into HMIS. Their community gets a few people who would like to join, but their services aren't really compatible with ending homelessness or wraparound services.
Yeah, I think that's a great question. And I did see another question pop up. I was trying to follow them all, but there were so many, such good questions. Was regarding like, do people enter into both systems? And actually, we only have a couple users within our health services department that actually have access into our HMIS system. So that this is why this bilateral communication and data sharing is so important, is because of that reason, right? They're pretty limited on who gets access into that system. And likewise, right, like in our electronic health record, we're the same way coming into our system. There's a lot of privacy agreements, a lot of training that's needed. It's a big lift. So we only have about myself, I have a user ID, and then we have about 6 other members within our system of care in the health side that have access into HMIS. And even those 6 additional don't actually have write access. They only have read access. So that is one thing. I saw someone also bring up the VI SPDAT. We are still working on kind of how to integrate those services. Many of you may or may not know, but we've seen challenges with the VI SPDAT in the sense that it's self-reported, and many individuals maybe are unaware of kind of, and don't state their medical conditions or kind of their risk at that level, and so it's not being accurately captured. So we're that's kind of next steps. Those are things we're thinking about. Same with our tuberculosis screening. That's something else. I know some counties, I have heard, in some states have been able to integrate this, and we're still working through the privacy issues that we have with that. But that is another thing that we're kind of hoping on in the next forefront. So right now, as of right access into HMIS from those who are in health services, we don't have really any access for that. Read access, there's only literally about 7 to 8 users that actually have read access.
Thank you. The second part of that question was that most organizations who are asking to integrate don't have the ability for data entry or caseworker for the HMIS, and so they were just asking for some solutions that you may recommend.
Sorry, can you say that one more time, Lauren?
It says most organizations soliciting this individual's organization to integrate don't have the ability for data entry or a caseworker in the HMIS, so just asking for some solutions you may recommend related to that.
Yeah, and unfortunately, I really wish our third person was on, Michael Fisher, because he would speak to this a little bit more. He's kind of our project manager over our HMIS system and those CBOs. But what I do know is our Health, Housing, and Homeless Division, which is within Contra Costa County, acting as that continuum of care representative. They have kind of a research, evaluation, and data team that does support all of our CBOs with this. So if they have some data entry needs, then they will help support them with that. Typically, it is about training them to do it on their own eventually. But if they need to support that for a couple of months or however long it is to get that data entry in, we do have that entity and that do help train that piece and carry that.
And I'll add that, you know, on the health side, we share a specific person's contact information, but on the flip side, it's really the housing program and kind of a general contact, because they don't have the same automated processes that automatically updates the phone number for the person if it changes. So that was a way to kind of reduce the data entry burden on the HMIS side and hopefully keep it a little more up to date if it's at the program level rather than the individual contact level.
Great. There are a couple questions in here that are kind of along the lines of the types of information that are available to access. Is there information that is shared with CBOs beyond contact information? And if so, are service providers HIPAA trained to be able to have access to some of that information?
No, at this time there isn't any information shared beyond that, and for that HIPAA reason exactly. So we just have the contact information, and then at that point, the case managers or the people within our health services department work on getting a release of information with those collaborating agencies, and then at that point they can share that needed information if possible once we get that on file.
And I'll add that at Contra Costa, we have like a universal consent form. So that covers all of our divisions within CCHS. So if you're sharing with public health, you're sharing with the hospitals, you're sharing with behavioral health and H3 as well, once that consent's on file. So a universal consent was another whole person care project that we've benefited from.
And then just to confirm, is HMIS and kind of the county also housed in the same kind of department as public health? I know that's not always the case. So
I can think. So public health is a division, and then our health, housing, and homeless is a separate division, but we're all under the Contra Costa Health Services umbrella. And the health, housing, homeless division is kind of the administrative entity for the HMIS system and continuum of care. So
perfect.
Separate from public health, we call each other like siblings within the family.
But the universal consent would include HMIS data. Correct. And okay, perfect. How long did this process take to get this whole system up and running?
Well, Allison, I'll let you kind of take the first part as I focused on kind of like this entity specifically, but I do think the data warehouse started long before this bilateral communication, for example.
Yeah, we're blessed. Our kind of business intelligence informatics chief, very visionary. Really in almost in 2012, I think we're at 10 years in now. They started the data warehouse process and starting with the EHR and other available systems. But HMIS was later, right? So technically it took until 2017 from when we started that process to be able to bring HMIS into this robust data warehouse. And then Lene can kind of speak to the interim steps for the HMIS process specifically, but long time coming.
Yeah, and then for the HMIS piece specifically, we started it probably about 5 years ago and actually got the data sharing information about 2 years ago. So I would say it took about 3 years for us to really, 2 or 3 years ago, so 2 to 3 years for us to really get that data information in there and accurate and validated so that it can continue to kind of automatically update and have accurate information. So it did take some time.
And related, I know that you touched on it a little bit in kind of the next steps and challenges pieces. And I know that we also talked a little bit about this in preparing for today. But could you talk a little bit about the costs associated with getting it up and running and maintaining it, and how you navigated what that looked like?
Allison, can you speak a little bit to like how much of that whole person care funding went into that piece?
I don't have it handy, but our total whole person care budget was 200 million, and I believe almost 2/3 of that was for technology projects. We certainly have the breakdown available. Apologies for not having that on hand, but yeah, having that one-time dedicated funding was really essential in getting it started, and then able to leverage smaller grant funds for maintaining the developer time needed when we have a change that we need to make, as well as pandemic funding as well.
And I know that I'm just going to call out one of the things you mentioned before, but thinking about kind of how to write some of the ongoing work for this into additional grants as kind of the maintenance of this work keeps going. So having the infrastructure is one thing, but keeping it updated is a whole other piece. So I think that was an important point that you made before. There's a question in here about the types of models that you've built and predictions that you've been able to make.
Sure, I can speak to that. So one of the largest projects our informatics team undertook is they hired a data scientist and did an internally developed predictive risk model around folks' likelihood for avoidable emergency department visits and other forms of utilization. And so that has inputs of lots of health history data, but lots of social history indicators as well, and homelessness and all the different ways that people hit our system related to the homeless programs is one of the large indicators. So we use that data for proactive enrollment into programs that are really supporting patients in more appropriate utilization of our available services. So that kind of risk modeling is one area. And then as part of the CalAIM initiative, there's a whole population health component that all Medicaid managed care plans, which we have one within our Contra Costa Health Services called Contra Costa Health Plan, will be expected to do to stratify their entire enrollment population and proactively enroll them into different levels of case management services. And homeless patients qualify for the highest level of case management services, which is enhanced care management. So that risk modeling segments the population. If you have a homeless indicator that meets the DHCS criteria, you can be proactively enrolled into that program.
There's a question in here about kind of how do community-based providers have access to the system? I think we talked a little bit about this, but just wanted to see if there's anything else you wanted to add about who has access.
Yeah, I think most of our community-based organizations, I have a feeling this is broader than what we're thinking, but most of our community-based organizations have access through our HMIS system into that data warehouse. So they will buy those licenses, for example, from our Health, Housing, and Homeless Division, and then be required to enter as well as utilize that information that's in there. But we don't actually, unless Allison, correct me if I'm wrong, but as far as I know, we don't have any other community-based organizations that are accessing the data warehouse necessarily outside of like our EHR or HMIS specifically.
No.
There was a question about if you use the Prepare tool for SDOH screening, social determinants of health.
Yeah, we don't. So previously we used an internally developed tool. We went through like a series of plan, do, study, act and piloting with different case management programs. And then most recently, just last year, we switched to Epic's kind of standard social determinants of health wheel, and then the accompanying screening tool that is kind of their out of the box SDOH tool. CCHS did opt to make some changes after piloting, but it's really the EPICS tool at this time. And then the state of California is working on a standardized screener as well that we'll implement when available.
Someone asked if there's any chance that this system is able to track folks who may have passed away and what their cause of death is. I know that homeless mortality data is particularly difficult to access, and this community saw a really dramatic increase, and they're trying to figure out why.
Yeah, that's a really good question. We did embark on a homeless mortality report end of 2019, and we were able to leverage the HMIS data to help identify homeless patients, but we had to go to vital records to get any information about date of death, cause of death. That level of information isn't stored in either our EHR or HMIS, and we aren't able to bring that into the data warehouse. So it was kind of a separate data request, but it did support us in identifying the patient population to match that cause of death data against.
And then have you, or if anyone in the audience has also done this, please feel free to either raise your hand to answer the question or type into the chat. Done any work on predicting homelessness prior to a person's experience of homelessness?
I can start, Lene, chime in. I wouldn't say it's part of any of our risk modeling, but we are able to segment our indicators by some screening questions that are asked, which asks about, how people assess their risk for their housing stability in the last, 30 days. So we can separate out those indicators. I think that's interesting, and I would love to hear from the group if folks have done that and kind of how. But that's the one thing that comes to mind, is being able to leverage the different indicators to look at different kind of risks related to homelessness.
And I know we've talked a bit about kind of data sharing agreements and kind of limiting access to information to address privacy concerns. But someone from Michigan has a statewide Medicaid EHR, and they are launching a homeless indicator from their HMIS database. And one of the challenges they're facing is that housing agencies are hesitant to collaborate with healthcare providers for the privacy reasons. And was wondering if you had any similar experience with some of that hesitancy and how you may have overcome.
Yeah, and this is, I directly don't know this information, again, coming from the health side, but I have definitely indirectly experienced a lot of different housing programs who actually input their information into HMIS, but it's not shared across HMIS systems. For example, other programs can't access that information. So I would say that we're definitely having that same kind of issue. So for example, in our programs who do have read access, they only have access to some of the housing programs that have allowed that information to be shared across programs. And then we have some housing programs that actually limit that information. So we are still working. I know that, every year or so we get one more program that's willing to kind of come over and have it shared. And I think really utilizing our continuum of care and our Council on Homelessness to kind of advocate for why we data share and what it means for the patients. And then also how it allows them greater access to services, other housing programs, other services within our healthcare system, for example. So really trying to advocate for that care coordination. I think also the other thing was the recent bill that came out about data sharing information, Assembly bill years ago, 3 to 5 years ago, regarding the data sharing that helps us serve our homeless populations. And so those actually helped people come into it as well. So really relying on that.
Thank you. I see, Gregory Dredd, that you have your hand raised, so I am going to allow you to unmute. So you may need to hit that on your
Okay,
end.
can you hear me?
Yes, we can hear you.
Okay, how are you ladies doing, first of all? And thank you both, all three of you, for your commitment to homelessness and to healthcare for the homeless. My question really goes back to the previous question dealing with the mortality rate. And myself as an African-American man, I have found in serving on the COC board, serving on the Healthcare for the Homeless Board of Directors, one of the things that really disturbs me is the disproportionate number of African-American men that are impacted through mortality. And sometimes some of the changes and the challenges that those men face are those families of those men, and some of the families are not even found. And I just wonder, where is the system going to, where are we moving forward in providing additional services, whether it's a broad service that can provide basic health, not health insurance, but like a small life insurance that if they don't have life insurance, it at least would cover the cost of a funeral. But also we need to have those numbers in place so that we are aware of statistically how many people, for instance, in Contra Costa County. I'm from California originally, but I live here in Texas now. But like in Contra Costa County or here in Harris County, how many minorities or women within the LGBTQ plus community are dying due to homelessness? And it's not classified under that stature. You understand what I'm saying? So that's a question for all of you.
I'll add, I had the opportunity to speak to some of our Bay Area counterparts in healthcare for the homeless who are working with homeless mortality data. And we just kind of shared our experience about how difficult it was to produce any report. Like this was very difficult data to get and took years of efforts on everyone's end, and sometimes required like direct collaborations with really collaborative, coroners, not easy. So just having that conversation with them and sharing best practices for how we can better collect this data. I totally agree. Sometimes that the visibility is not there yet, but we need it to be. And then I've appreciated leadership on Contra Costa's end. We've hired a new chief equity officer and have a new data governance structure that's put in kind of requirements that if we're looking at any population health management data, we need to make sure that we're stratifying it to identify disparities and not just have one outcome, but what are the disparities across all the different segments of our population. So I appreciate the question, Greg.
Yes, second that, really appreciate the question and you raising that. I think disparities in health, disparities in mortality rates, disparities in homelessness are all very staggering. And our lack of ability to really understand what it looks like on the ground is doing a huge disservice to the people that we're trying to serve. And I think that's I know that's something that the council is committed to addressing. I know that we've put together a mortality toolkit working with different communities to think through how we can better understand what the issues are and how we can better capture exactly the information that you're talking about. I think there's a long way to go. If you are interested in more information, I'm happy to connect you with the people that are doing that work. But I agree that this is something we need to be doing more of and we need to be stratifying better. Thank you, Joey. Joey just put the toolkit in the chat down there. We have a couple more minutes. So one question that came up was, again, around kind of the release of information. part of that is asking if it's possible for you to share the data use agreements that you use in your community, and what that looks like. I know that you have the universal release.
I'm happy to confirm, but I know we have shared our universal consent and then the release of information that Lene spoke to a little bit, which is on top of that, kind of sharing outside of Contra Costa Health Services. We identified some key community providers that are listed on that form. I'm just going to confirm real quick with our kind of governance structure that that's okay to share, but I'm pretty sure we've done that in the past. So we would be happy to if we get the permission.
Thank you. And then do you know if there needed to be any changes to the HMIS release of information protocols to allow the integration in the data warehouse with the EHR?
I was trying to get the answer to that question because, again, that's on the other side of the house, and I really wish Michael was here because he would be able to answer these questions. I will reach out and I will ask. I'm actually looking at it now, and I will, if it's public information on our public website, what that release of information is, I will definitely share the link here. So I'm looking to grab that because I did see that right now. I will try to get that answer and I'll send it over to Lauren so that she can share that with you all as well.
Thank you. And then there have been a couple questions that are related to specific vendors. And just with our last couple minutes, wondering if you could speak to any challenges working with any of the vendors involved, whether it's from the EHR side, the HMIS side, the data warehousing side.
I think we've had a pretty good experience. I will say we hire quite a few contractors for our internal business intelligence informatics IT department who have previous experience working with Epic mostly. And then I'm not sure if you can speak to the BitFocus side, but I think BitFocus was purposefully selected because we knew it would better integrate with the data warehouse. But we have pretty good contacts on the Epic side. Contra Costa is a pretty big customer for Epic as we use it for our entire health system. So on the health side, had pretty good experiences and they've been supportive, and we've presented out on some of our data sharing work with them as well.
I'm going to launch our evaluation and ask one more question of you. So if folks on the line could just answer these 3 quick questions. We will be sending out the recording and posting the resources available. They'll be available on our website, and we will try to get this out to everyone as well. But my last question for you is, what do you wish you knew when you started this work?
Is that for Lene and I?
Yes. Sorry.
Sorry, you guys. What did I wish I knew? It's a really hard question. I feel like we learned a lot through the process. So I think what I wish I would have known is a lot more, had more of these sessions to attend to and hear what people had to go through to kind of get this started. And then also just the implementation process and then also the manpower that it does take from our BI side, as well as from each division side, and each platform side, what that ongoing need is. Because I think, a lot of times we get this funding, this one-time funding, we're like, wonderful, let's do this. And then we don't really think about what does it take to maintain those systems. And I think that would have been helpful for us to know ahead of time, most definitely. So I would say that was something, and we still struggle, right? We have had people leave and come back in. And so educating these people, especially on our BI side, and having to reset, reshare, okay, this is what's happening, this is how it's happening. We've actually seen some of the data integration kind of drop and help us as the managers on the 2 divisions kind of revamp that process with our business intelligence team as people come and go. So that is definitely needed, that I probably wouldn't have anticipated until we were in it.
I'll add on my end that I still wish I knew more about our partners at H3 and all the services. You know, Lene has done a ton of legwork to be able to be knowledgeable of both sides, and this whole effort is designed to break down the silos. And sometimes I still feel like, wow, I'm so focused on, you know, the public health side. I wish I knew everything about H3 and the CBOs that participate in HMIS and all of our homeless continuum of care. So this process has definitely helped, but recognizing it's beneficial to have the knowledge on both sides and really put in the effort to build those collaborations and build that knowledge space between health and our homeless service providers.
Thank you. Thank you both so much again for sharing all the work that you're doing. Really excited to see where it continues to go. And thank you all for attending, for your questions. Please feel free to reach out and ask more. We, Joey and I are very excited to continue this work. So if there are things that we can do to support, let us know. Have a great rest of the day, everyone.
Thank you.
Thank you.